All right, good afternoon, everyone. This is a reminder, this is the Lunch, Learn, Link seminar, which is sponsored by the Kimmel Comprehensive Cancer Center at Johns Hopkins, as well as the Maryland Department of Health Cigarette Restitution Fund Research Grant, also at Johns Hopkins. So I'd like to welcome everyone in the audience, as well as the audience that are joining us online, and especially those listening at the Department of Health and University of Maryland. Before I introduce the speakers, I'd like to remind everyone in the room to make sure to get a ticket for pizza. We're having lunch immediately following the seminar in the gallery, and you can get a ticket from Nicole. She's waving her hand, and she will be outside by the door once the seminar ends. All right, so these two investigators, Dr. Chander and Dr. Hutton, have been conducting a pilot cigarette restitution fund project to develop and to evaluate an avatar to assist smokers to quit smoking. Dr. Geetanjali Chander is an internal medicine physician who is interested in helping all her patients who smoke and help them quit. She evaluated the Johns Hopkins EPIC module, by which physicians make an electronic referral to the MD Quit line. Dr. Heidi Hutton is a clinical psychologist who has applied motivational interviewing to the task of building a responsive avatar. Please help me welcome them in their talk, Development and Piloting of Avatar Counseling to Deliver a Cigarette Smoking Intervention.
So Heidi and I are going to tag team this as we do with everything. So let's see. So we're going to, this is just an overview of what we're going to talk about, some background, what works in treatment, why we're using technology, how we develop the program, and some description of initial testing. So I'm actually going to explain that this actual initial grant actually was written for individuals with HIV who smoke. And so our background is really related to that, though we have been moving towards actually tailoring this in general to individuals in Baltimore City. So the prevalence of tobacco smoking among persons with HIV in the United States is twice that of the general population. And there's an even higher prevalence among certain subgroups, which is probably not surprising to any of you. Individuals with HIV who use alcohol or other drugs, have high concurrent mental illness, and persons of lower socioeconomic status. And while smoking rates are declining overall in the U.S., individuals with HIV are less likely to quit smoking compared to smokers in the general population. So why, outside of the prevalence, why think about smoking among individuals with HIV? Well, cigarette smoking is actually the biggest threat to health-related gains achieved from antiretroviral therapy. So among individuals with suppressed HIV on therapy, there are more years of life lost from continued smoking compared to HIV infection itself. Smoking among persons with HIV is associated with an increased risk of lung and other smoking-related cancers, cardiovascular disease, and pulmonary disease. And in a sample of nearly 18,000 individuals on antiretroviral therapy in Europe and North America, individuals who smoked had nearly twice the mortality of those who did not. And this mortality was attributed to cardiovascular disease and non-AIDS-related malignancy. And importantly, cessation results in a reduced incidence of cardiovascular disease and smoking-related cancers and improved quality of life. So why technology-delivered interventions? So novel technology-based interventions can incorporate evidence-based behavioral and pharmacologic interventions for smoking. And they can be culturally tailored to offer real solutions to numerous implementation barriers. It's not surprising. It actually, if you think about sort of how do we really disseminate evidence-based care in practice, it's hard. We're busy. Whether you're seeing patients or you're in a public health setting, really thinking about how to optimally deliver care is time-consuming, and there are multiple barriers. So these computer-delivered interventions can be tailored to individual groups or populations. They can overcome many of the barriers that are experienced in providing evidence-based interventions and clinical care. And they can be efficacious in reducing smoking. And they're significantly more effective than usual care or written self-help materials. Technology-based interventions also appear as effective as counselor-delivered interventions in reducing smoking. And there's a growing body of evidence that strongly suggests that these interventions offer promise in reducing smoking. They have the potential to reach significantly more patients and the ability to overcome barriers of cost, implementation, and cultural non-specificity. So what are the goals of this program? So the first thing that we set out to do when we started this work was to refine a smoking cessation program that includes a computer-delivered intervention with an avatar using evidence-based behavioral change techniques. So we were refining the intervention based on patient and community and expert feedback, such that the avatar and intervention content were salient, acceptable, and engaging to diverse individuals, and specifically diverse individuals in Baltimore interested in quitting and reducing tobacco use. And then the second goal was to pilot the intervention in the Johns Hopkins HIV clinic, a clinic that serves low-income individuals from Baltimore City who currently smoke, to determine initial efficacy of the intervention and to calculate the sample size for a larger trial. And those results are pending. So I'm going to pass this on to Heidi.
We're going to move back and forth, as I said. One of the things, Geetanjali and I started working together almost 20 years ago, and we shared many common interests and goals, and one of them is that we both strongly believed in having a theoretical model to guide our work. And so the one we chose was actually developed originally for HIV, which worked out well because that's how we met, was through HIV. And it's the situated information, motivation, and behavioral skill model, which I'm sure you all are familiar with or have seen at some point. But it works really well for us because the original IMB was just those three components, and then Reve Amico added the situatedness, which is really important when you're working in Baltimore City. I think particularly our patients in the HIV clinic function within this milieu that has many challenges, and you all live in Baltimore, so you know what those are. And so it allowed us to evaluate also the pressures that our patients experience in the context of navigating care at HIV and also in the JHH medical system, which is not easy, and also just navigating through Baltimore City. So our context for developing this program was largely low-income, HIV-positive people from our clinic. So we're going to sort of walk you through the steps of how we developed this intervention. First of all, we sat back and thought, okay, what really works in mental health? What do we know? What helps people reduce smoking, reduce alcohol, or any other behaviors in the addictive spectrum? And first we thought CBT, which is cognitive behavioral therapy, widely used. Again, I'm sure you all have heard of it. But it explores positive. So we pulled out some key components that we thought were going to be relevant. So obviously, positive and negative consequences that people evaluate before they use a drug, alcohol, cigarettes, or other drugs. It also helps you to anticipate and prepare for high-risk situations and develop strategic coping behaviors. Motivational interviewing. How many people are familiar with motivational interviewing? Show of hands. So about half of you. Okay. This is both a style of approaching people. There are some techniques within it, but largely it's a style of interacting with people. We just did a project in Uganda for HIV positive, at risk, or currently infected, and used MI with community health workers, and the MI was just a huge success. It's a way of approaching people with a non-judgmental, open-ended questions, reflecting where the person's at rather than coming with your own agenda. There's a quality to the counseling situation which you don't see in sort of more paternalistic healthcare. So we wanted to take those qualities and incorporate that because motivational interviewing has been effective in so many settings, and now we know globally. So then we thought, well, what works in computers to help people change behavior, or web-based delivered interventions? And you know, when you're going to go into this literature, you've got to go way outside PubMed. So there are all these journals like Human-Computer Interaction. Who knew? That's not in PubMed. So we ended up discovering some really cool publications in engineering and the military. They published things on the use of avatars and computerized counseling. So it's been a kind of an interesting voyage. And so some of the things that we abstracted from that literature was about tailoring to the individual, targeting to the group, sometimes normative feedback, which is like saying, most people don't smoke, that sort of thing, developing coping skills, aesthetic design, emotional support, having an avatar, and the list is actually quite long. It's a rich literature. So now we'll walk you through our 4 steps. And this turned out to be a much more complex project than we thought. What you don't know can kill you. We're very grateful to the Cigarette Restitution Fund because they have funded us for 3 years to develop this project, and without their support, it would not have been possible. So our first step was intervention content development, and we began with qualitative interviews. I love qualitative interviewing. It's just awesome. I came from a quantitative background. I'm a psychologist. We have all kinds of measures. I was never taught anything about qualitative interviewing. That was always something I learned in the context of seeing patients. But I've actually, thanks to Geetanjali, learned the systematic approach to qualitative interviewing. So we used that. We were interested in making sure our intervention was culturally appropriate for our patients. Now, Geetanjali and I both work in the Bartlett Clinic, the HIV clinic, so we already know how our patients speak. And there's a lexicon, there's a way people frame problems, there's a way they speak of the problem, what words they choose, and that was very important to us in developing the intervention, that we captured that. But we also did it systematically with qualitative interviews. We also wanted to make sure, and part of cultural adaptation is pulling out these core components that work across cultures and across time, and then adapting the key characteristics, which is where the qualitative interviews are really helpful. And then we wanted to explore specific intervention components, like why do people smoke? Why do they smoke before? Why did they start? Why do they smoke now? What does smoking do for them? Obviously, it does something positive or they wouldn't do it. What are their triggers? What causes them to want to pick up a cigarette besides just physiological craving? And then reasons to cut down or quit. This is important because we're trying to motivate people to change, right? So we got to know what their reasons are. For us, for Geetanjali, she can give you all the medical reasons, right? Because she has a long list of those. But it's helpful to know what our clients who might use this program would actually say. And they're different from what you find some nuggets that you hadn't thought of. So this came out of Reasons to Quit, the qualitative interviews. I won't read all of it, but it says, right now, it's helped as far as my grandsons because they're happy. I don't smoke because when I was smoking, I'll never forget my grandson. He's 10 now. He was 9. And he said to her, I know, this is what actually, I was remembering who this woman was. Why do you want to die? And she said, well, I don't want to die. Yes, you do, because everybody's telling you to stop smoking and you can't breathe as it is. You can wear your oxygen, Grandma, and you take the oxygen off and go smoke. And the participant said, the interviewer said, how did that make you feel? It made me almost cry because here is this child asking me, why do I want to die? The thing is, he depends on me to be there for him. He depends on me instead of his mother. So we heard a lot about the importance of family when we did these interviews, that was a strong motivator to smoke. And quite frankly, we were fixated on the reasons that were relevant with our own particular fields and hadn't thought about bringing in the family as much as we should have, I think. The same client that we interviewed talked about the importance of having intergenerational videos. She's a very smart woman, and having children talk to grandparents and sons talk to fathers and fathers to son. And so that's part of our next step. Okay. Smoking and stress. It's stressful living in Baltimore City. So it's interesting. Seems like everyone smokes in Baltimore. Yeah, everyone smokes in Baltimore. They have kids. Everyone else sees it and feels like cigarettes were relieving me from stress. Smoke a cigarette and you think it's better, but everything's still the same. While I'm smoking a cigarette, it did calm my nerves to the point I wasn't even thinking about why I was smoking. It just made me feel calmer. And like I said, having a cigarette, it calms me down for a bit. So one of the, and also what's really cool about doing qualitative interviews is that your clients, your interviewees, will suggest terms that you can use. And so one of the people that we interviewed said, "Oh, you need a reset button." We thought, oh yeah, a reset button. So that has become how we call this. We had to go in search of a reset button, which we have found. So then we gathered the information from the interviews, and because we are model-driven, we wanted to fit everything into what information do clients need, what motivation is important, and what behavioral skills. So this is just an abstract of a few of the themes from the qualitative interviews that we did, just to give you a flavor. But one of the things that mistakes or assumptions that we always make is that and I think this is probably true of ourselves when we go to the doctor, we don't always gather all the information that we need from medical appointments. Geetanjali will read you a funny quotation later. But our clients, our patients, our clients are hungry for more information. And I think it's very overwhelming when they come into a doctor's office, as it is for any of us. And we think that they take away more information than they do. And the computer actually turns out to be a very effective way to deliver information because they can repeat it. And it goes at their own pace. Whereas, a busy physician is rushing through instructions. So they also were... virtually, I think none of the people whom we interviewed realized that or understood that you could reverse the effects of smoking, and they didn't know what that entailed. So that was another opportunity to introduce some information. We ended up making a video, which I'll tell you now because you won't see it on the little clip that we're going to show. But we did this great video. It's called Turn Back Time. And it shows, Geetanjali, you want to describe it?
Oh, sure.
We'll let the physician describe it.
So it was actually really fun. We worked with a local animator because what we realized was it was clear people didn't understand that you actually can see some immediate improvements in symptoms, like your shortness of breath will improve very quickly, that your blood pressure can go down, within 20 minutes. And so we ended up creating a short, about 4-minute animated video that literally takes someone through how you can really turn back time and how you can, from symptoms to reduced cardiovascular disease to, reductions in cancer risk. But it's humorous and it's all in really lay language. And actually, we don't have any of the quotes from that, but in piloting it, the patients loved it because they actually finally felt like they understood because it was clear and it was engaging. Mm-hmm. It's unfortunate. We just didn't want to take 4 minutes of this talk to show you.
Yeah, it shows, it is humorous, and it shows different body parts going back in time and people running upstairs when they could only sort of walk like this, but they loved it. So that was a very successful piece. This is our final model. So it gives you an idea of the complexities of setting up an intervention. And within these subtitles are actually, or within these titles are subtitles, subcategories that describe the intervention. But again, as I said, we were very model-driven because that is the evidence base, and we like to stick closely to our evidence base so that we know going in that the computer model, the computer intervention, will contain all the known techniques and methods for changing behavior. Software development. This is where we underestimated a little bit about what was involved. We made a long list of our system requirements. There are things like we wanted modular platforms, so if we didn't want to discuss cigarettes, maybe we wanted to focus more on alcohol, or we wanted to add in more information about mood disorders. We wanted to set up algorithms so that maybe we could address multiple concerns of different patients. we wanted to insert videos and pictures. So our first iteration had many pictures of Baltimore as they worked through the intervention. It had to be engaging, it had to be interactive. Well, how do you interact with a computer program? When the avatar talks to a person, they can't, we're not sophisticated enough that they can type in their answer. They have to answer on multiple choice. I mean, it's just the state of nature with these programs, and we're not Pixar or Disney. So, so then, who can do this for us? And Geetanjali actually found a local video game company, and they did the Pet Rock that was on, I think that's their claim to fame. If you all saw that on Facebook, I think that's old now, but I don't know what else they've done since then, but they got us started, which was great, and they did it because we paid them a little bit, but it was pretty much pro bono. They were interested in doing something about substance abuse in Baltimore. We had to have concerns about server and confidentiality and how to edit the program and front end and how to collect data. I mean, it's quite a massive undertaking. Then there's a challenge of how do you make a counselor-delivered session into a computer-delivered session. So we have to integrate the information from the in-depth interviews and CBT and motivational interviewing and our clinical experience into these scripts, because you're animating like a cartoon. And we also want to incorporate our theoretical model and our evidence-based techniques. And it's like, okay, so how do you make a counseling session with not much money and pretty primitive software? So you try and branch as much as you can to personalize the intervention to the client's needs. And then you try and create an avatar who's emotionally expressive. We'll get a little bit more into this. And then you have to create some way to interact. So you ask questions of the person, and then they interact. They input, or they, using multiple choice, will provide an answer, and then the avatar has to answer. So it becomes complicated because you want to make it as realistic as possible. And then thinking about the avatar, a lot of computerized interventions don't use an avatar at all. But because we had read outside the PubMed literature into the journals of human computer interaction, we felt that avatar was very important. And there's a fascinating literature on the development of avatars. I mean, if we had money, we could do something really awesome, because I think we have a good understanding of what is necessary to create a convincing, persuasive, and perhaps even a little bit manipulative avatar, which is a little scary, but so we identified what the key characteristics were and tried to develop them as closely as possible to be human, but actually better than human. Empathy, support, and acceptance, eye contact, and then how to find a voice. Do you want to talk for a while?
Yeah, no, it's fine.
Okay.
Well, the voice was hard,
Yeah.
and we struggled a lot with the voice. I will go back a few slides and say, so prior to doing this work through the CRF, we actually had done the initial software development. So this is actually not 2.5 years of work. This is more like 6 years of work, just to give you some context. So we had already developed the modular platform software. I thought I should probably say that, so that
it's worse than we represented.
Yeah.
It's longer.
And there are issues. So when we first started finding a voice, like all there was Microsoft text-to-speech, and so our original voice was very robotic. And about 18 months ago, we were able to actually get the Amazon Poly voice, which is a little better, but it's a struggle, right? Because we're trying to create a conversation. You want the individual to be able to relate to the avatar, and so the voice has to be right. And then when you're typing in the script on the back end, you have to do things to ensure there's an appropriate pause, for example, or that when you're conveying empathy, the voice changes a little bit, and map it with an arm movement. So it's, but voice has actually been our biggest challenge. Interestingly, it's better, but it's not quite
It's
there.
not our biggest challenge.
No. Well, one of our
biggest challenges.
One.
Yeah.
No.
Yeah. Fortunately, Geetanjali found the voice, so that was good. So these are our avatars, and actually we've changed. We started with, this is Petey the Parrot, who was our first avatar for an alcohol intervention, and we've had very good results with that. We actually reduced not only statistically, but clinically significant reductions in drinking. And then our second avatar was the Baltimore Raven, Geetanjali named Poe. And then this is our current avatar. Her name is Edna Poe. And we've actually modified, you'll see on the video, we've modified her features. So she sits behind a desk and dispenses her information. So then you come to intervention testing. So there's a lot of testing that needs to be done, as you might imagine. The intervention has to be clear. The content has to ring true to the participants who are taking it. It has to be usable. Like, can someone who's not particularly computer savvy actually navigate through the program? Because eventually, of course, we want this to stand alone in clinics so that people, while they're doing the shorter or longer wait at Johns Hopkins, can have something to do, and they don't need to keep asking a clerk, how to how to operate it. What we do is a think aloud method, which as our study participants would go through, they would make spontaneous comments about the intervention, and we record those. And then at the completion, we have several measures that we developed to assess the usability and likability and how well the avatar related to you and so forth. And also message framing, specific suggestions that they felt would be useful for us. These are some comments. So on acceptability and utility, and I think these perhaps are not surprising, but if you read through them, I knew some things. Hearing from the computer was like hearing it for the first time. I thought that was really interesting. A lot of people said they learned more about HIV and smoking and drugs and alcohol, some of the other ones that we've piloted, because they had time to reflect on it. They could push the repeat button. And it was if you follow the next comments, it was a judgment-free atmosphere. So it was on their own time. This is a comment on our female avatar. She doesn't lecture you. She informs you in ways to get yourself together. And once I picked a topic, she went straight to it. Of course, it went straight to the topic because, of course, the algorithm was programmed to go straight to the topic, but I don't think she even processed that. She just was following along with the intervention. She liked how they used the words mess with, because we picked local terms, like, alcohol messes with your brain, or smoking messes with your relationships with other people who are not smokers. Delay, discuss, and do something else. This is our hip pocket behavioral mnemonic for what to do when you get a craving for a cigarette. So under the negative, they liked that, but under the negative, they wanted more information about HIV. The program could be a little longer. We actually felt it was actually too long ourselves, but it's interesting when you get comments. And this is actually, I think, really interesting. A lot of the patients talked about how they wanted more information on the negative consequences. This is really interesting to us because we shared the program with a national expert on smoking, not from Hopkins, from another institution. And she said, there's way too much on the consequences of smoking, negative consequences of smoking. So it's just really interesting. So do you want to do so?
So we got a lot of feedback on the avatar as well, and I think there's some really important things here. So the one participant said, "I'd rather have the computer counseling because it gives you control. I felt like I could go in and be honest with the program." So I think that word honest is important. With the computer, it's not as personal. There's no one to judge you. So, I'm a medical provider. So these are things like I read and I thought, like, this is really important, right? Because, as a provider, how am I controlling my facial expressions, or am I conveying judgment? And when I heard this, I thought, well, this really makes sense, because this avatar, there's no judgment here. Whether you're smoking or using cocaine, it's not there. And I think that that's something where I, as a provider, I don't do as well. She was very sensitive and concerned. I picked up feelings of sensitivity and concern about the whole situation. So that's all about, the script that's written, the empathy that's actually put into the script, but then also how you have that avatar convey empathy. And here we go. Cartoon character makes it a lot easier because it doesn't express facial emotions that a doctor might when they are thinking about you. The cartoon makes you more truthful. And then how does Poe compare with a counselor or provider? She is a provider. So really, people really saw this computer program and said, this is a provider. And then we, some of the negatives, they thought the avatar could be bigger. It's a good place for a person to start, but I would not want Poe to replace my therapist. So I think, then we did some preliminary intervention testing, as we said, and where we did the think aloud procedures, where we got some initial satisfaction. And among 8 individuals, 50% of whom were women, median age was 54. You can see that there was a range of education, some college education, some individuals with GED, some with some high school. And actually, computer use actually varied as well. Half of the sample did not use computers daily. And the satisfaction was high. All the participants endorsed, I plan to use some of the information from the program to change how much or how often I smoke cigarettes. And none felt that the avatar was judgmental. And the overall satisfaction score was 4.75. But this is my favorite quote, which is why Heidi passed it over to me. So we asked if, we asked a number of questions. This is actually pretty extensive, and there's a lot of qualitative, semi-structured questions. Asked if they preferred the computer to a person. And the patient said, the doctor's not better because they say, if you don't do this, this bad thing will happen. Most people don't listen to their doctor anyway. And I was like, that's important when we think about how we talk about this. Let's see. All right, Heidi.
I want to say that we reported those results from that particular qualitative interview, which is a sample of 8. We've actually done a number of sets of interviews, but we just pulled the data from there. And those of you who do qualitative interviewing know that you don't survey copious numbers of people anyway, because otherwise you would kill yourself in qualitative interviewing. So this is the final intervention outline that we developed. We have session 1, and now we're working on session 2. But based on all the information that we put together, these are all the areas which the avatar will cover. And I think that I'm not going to run through too many of them, just in the reasons why they started smoking initially and now, because those are very different reasons, and we wanted them to reflect on the difference between those two. Identifying the downsides of smoking. We want people to reflect for themselves what are the downsides of smoking rather than us telling them about it, or the provider. We wanted to provide hope, so we have the Turn Back Time video, which, as we said, was very effective, and what you won't see here. And then it gets down to sort of the meat and potatoes, which is how do you manage cravings and triggers? Cravings being the physiological symptoms of addiction, and then the triggers are what makes you think about lighting up a cigarette, which could be cravings, but it could be a lot of other things as well. And then what to do about the cravings, and then reviewing what to do about triggers. And again, we wanted to go back to a hopeful message, is how will your life be different if you quit smoking? And then at that point, people are invited to think about goal setting, that again, it's done in MI format, so it's not forced upon the person taking the intervention. It's just says it introduces, like a lot of MI, some people, having heard this information, have thought that they might like to set some goals, and some people not. So it's never forced on the person. And then the final is motivational endings, just to sort of cheerleading, as it were, about you can do this and you can't go back and you can't make a new beginning, but you can go forward and make a new ending. So just motivational messages, which again are drawn from the literature. Okay, having said that, I think we'll show you a clip of what the intervention looks like. This is where our disclaimer comes in, because it is really hard to create software on a budget that makes what we're going to show you is our beta version. It ain't Pixar. That's all I can say. So please adjust your expectations accordingly, because she is it's a simple character actually, we spent a lot of time developing this character, but what you can translate into the graphics is much more difficult. So we're going to show you a short clip. This will not give you a flavor so much of the intervention, because there's too much to pack in. So she's going to jump around. All the different screens come up, and each time different screens come up, the person is asked to interact and answer questions about themselves. So, what do we do here? How do I get her started, do you know?
Actually goes back to the original MP3.
Yeah, here we go. I just can't see it on my screen. There's always a technical. I'm sure there's a way to do this. I just don't. There's media player. Oh wait, there we go.
Hi, I'm Edna Poe. I am glad to meet you and welcome to my internet office. I have some information that might be useful to you. I am not here to judge. I'm only here to guide you through some ways to quit smoking, if you are interested.
Okay, I'm going to pause there and just point out a couple things. First of all, notice that she has very large eyes, which we know from human-computer interaction is very important. And she doesn't get up and move around because that's extra money. So she talks behind her desk and gesticulates. Thank you for your understanding. If you know anybody from Pixar, please have them call us. And she sets up the interaction right away that she's not here to judge. Now, that's very important, because you've got to set the context. And believe me, that resonates. I mean, what we see in you guys as sophisticated computer users versus some of our patients who the HIV population is aging, and some of them are in their 50s and have not used computer programs, this stuff looks pretty cool to them. So it does the trick.
Many of us smoke. Some of us are not ready to quit, and some of us have tried to quit many times. We may also be getting a lot of pressure to stop from our doctors, family, and friends. So
again, that statement is supposed to connect with them, their own frustration about not having quit, right? It's because most smokers now who come into any clinic in Johns Hopkins is going to get some hairy eyeball from their physician or a staff member. They're going to get a message that it's time to quit. They just don't know how to go about doing it.
Started smoking because I felt sad or angry, and cigarettes helped me feel better. So, let's think about now. Why are you smoking these days? Please select all that apply to you.
So that's where the person interacts with the program.
You checked off that you smoke now because 1. Cigarettes sometimes feel like a friend. They are always there for me. Many have said cigarettes can feel like a friend sometimes. But they also said that a real friend doesn't betray us. It's the downside of smoking. So, now, if it's okay with you, let's think more about this downside. People from Baltimore also shared a lot of reasons about why they thought smoking was not good for them. So, you listed 9.
Okay, so I'm jumping way around, but what she does is she talks about exploring the positives, and now she's going into, then the person interacts with the program about what they think are the downsides of smoking, right? And so this person picked cancers and stroke, which is not usually what our patients pick. They usually pick other reasons.
Smoking can cause cancer, strokes, and heart attacks as the downside of smoking. On the one hand, you have reasons why you smoke now, but on the other hand, you see negative effects from smoking too. Sometimes.
Okay, so those of you who raised their hands about motivational interviewing will recognize this, right? On the one hand, you smoke because of this, and on the other hand, on the one hand, you'd like to quit for this reason. On the other hand, you want to keep smoking for this reason. That is a very powerful interactive moment in behavior change, because what you're doing is you're asking the person to consider the discrepancy in their action, that they have one value on this hand and another value on that hand. And so we tried to have the avatar capture that by literally on the one hand. When I talk to patients, I don't think I actually do this and this, but we're trying to make it a little bit more graphic for the person. That works actually more effectively in getting people to change than someone coming down on the negative consequences of their behavior. Because think about your own arguments that you might have with a spouse or a friend or your dog. You know, if you come down on the negative consequences, then the person with whom you're arguing is going to tell you all the positive reasons why they do the behavior, right? It's a natural human tendency to create that balance, to give the opposing view. So actually, if you want to change behavior, sometimes you can focus on the positive reasons of smoking so that they can argue for the negative reasons. I mean, that's essentially what you're trying to do. Okay, does that make sense? You obviously did motivational interviewing. No, but you got the concept. Okay, good. That's awesome.
We keep smoking just because it is what we have done for a long time. And sometimes people tell me that they feel discouraged and wonder if quitting will really make a difference. What if you could turn back time on smoking?
So this
The
is where
damage
we
from
go into
smoking,
the
unlike
video,
the
which I'm
damage
sorry
from
we
many
can't
other
show you.
diseases, can be undone. Many people want more information at this point. They want to know if they were going to quit, what would be the first step? So, the first step is understanding the moods or situations that make us want to smoke. These kinds of moods or situations are called triggers. By figuring out what our smoking triggers are, we can start to manage them. As it is said, if we can name it, we can take some.
So just going back there, all the reasons, the triggers were drawn from our qualitative interviews. We didn't make any of those up. Those are all the ones that the folks gave us.
People find that a short saying helps them to remember how to handle triggers.
Again, this goes slowly so
A
that
saying
people
that has been
process
shown
it.
to work is called the 3 Ds. It stands for delay, discuss, and do something else. The 3 Ds, I love the way that sounds. Delay, put off lighting up that cigarette to see if the craving to smoke passes. Put your cigarette down between puffs. Also, instead of holding onto a cigarette, get a non-alcoholic drink, a pen, a toothpick, or something else that you can do with your hands. So, I am curious, which of these delay solutions would you be interested in trying? We reviewed the first 2 Ds, delay and discuss. Now, let's review the third D, do something else instead of smoking. To do something else, we have to reduce cravings to smoke. And, we also have to do something about the trigger that made us think about that cigarette. So, first, let's review a few methods that can help you do something else about smoking. The second do something else.
So obviously we've skipped ahead here. She has, at this point, again, this is our beta version, and she has a limited number of movements that she can execute. So Bugs Bunny, which we would be happy if we had a Bugs Bunny. Bugs Bunny has about 3,000 movements, and this avatar has probably 25 or 30. So we're very limited in what we can program. You notice that she leans forward when she's going to say something of importance. She can do her hand movements, blink her eyes. But obviously you need an avatar that would be great if she could get up out of her seat and come around to the front of her desk, and she was a little more three-dimensional. Oops.
Method is to call the Quit Line. Quit Line is free telephone support that provides counseling and treatment to quit smoking. The third do something else is to talk to your provider
plug
about
for the Quit
medicines
Line in
that
there.
reduce withdrawal and block the nicotine effect you get from cigarettes. The fourth do something else method is to go to a support group, like Smokers Anonymous, and work with others to quit smoking. Besides do something else about cravings, we also can do something else about your trigger that you...
One of the other funny things about doing a computer program is they say things that are weird. So she says nicotine, like with a G. Like, why does she say it that way? I don't know. We tried to put different words in front of nicotine. We had another avatar who said hallucinogens instead of hallucinogens. We could not get it to pronounce it correctly. So there are all these funny things that you run into. These suggestions about doing something else, again, these are suggestions that came up from our clients and also what we knew from the literature.
You said was feeling sad or angry. Here are suggestions. 1. Reach out and share your concerns with a friend, not with a cigarette. 2. Go for a walk or someplace that is smoke-free like a mall, restaurant, clinic, or a bus. Get active and get moving. It helps boost your mood. Whoa, those are some powerful things that could happen if...
Okay, so she's just talked to them about what are the good things if she quits smoking. So she's now reflecting on that.
You quit. It always helps to remember the good things that can happen if we quit smoking. Thinking about the good things can make us feel happier, more hopeful and more motivated. And we know that hope takes us a lot farther than fear. Now that we have had a chance to think about smoking, many people are ready to try to cut down or quit. I am interested in your thoughts, but I am not here to judge. Congratulations on setting a goal. Your goal is to cut down on how much or how often you smoke. I hope that many of the ideas we discussed today will be useful to you. If you slip up as you try them, do not give up. It may not be easy to quit smoking. It will just be worth it. Even though no one can go back and make a brand new start, anyone can start from now and make a brand new ending.
So one of the other things that we skipped over is that she takes people through what we call the reset button, which is teaching people deep breathing, sort of a meditative technique. We had the avatar do it, but we're actually going to make a movie of a person doing it and embed that into our next, what we hope will be our alpha version, because that reset button was so powerful. Our patients talk a lot about, you're in the midst of something terrible coming down in a family or in the city, and that cigarettes are that moment, that 5-minute moment that you can check out and find a bit of calm. So what can you always carry in your hip pocket that's always there and it's free and doesn't depend on people? Because they talked a lot about the fact that cigarettes, you don't need to depend on people. And having that moment where you can do deep breathing and a meditation seemed like the best method. So, but we have to do, that takes quite a bit of instruction, so a video is going to be what we're going to do. Anyway, do you have any thoughts?
Any questions?
Thoughts? Yeah.
So when you, thank you also, I really enjoyed all of that. When you actually introduced with Edna Poe and the program to people who said that they did enjoy it, were you able to do any follow-up with them to see whether they actually did stick with those plans?
Yeah, so what we did, we haven't actually analyzed the data, but we actually did a 40-person pilot RCT, and really not with the idea that we would actually see smoking cessation with one session, because this wasn't delivered like in the clinic where you then have immediate access to a clinician who can give you NRT, et cetera, and so our primary outcome is actually intention to change. So we haven't looked at that yet. So, but we did a pre and then immediate post intervention, and then a 1-month follow up. And so we'll see. I'm not sure. I suspect in the pilot that many people probably said they had a high intention to change at baseline. But we haven't looked at the data. So my guess is, I'm not sure. We'll see what we see. Because there may have been some sort of social desirability to say they're ready to quit today. This was just a small way for us to start to get some feedback. I will say, ultimately, the idea is to deliver this in a setting where people actually have access then to varenicline, Wellbutrin, nicotine replacement, Because ultimately, if someone's ready on that day, you want to be able to give them the therapy.
And then our second session, we're going to do an in vivo. The avatar will guide the study participant through an in vivo placement of the patch, or they'll put the patch on and they'll do the gum and lozenges so that they can explore the side effects that they are often afraid of from our qualitative interviews, so that they can do it and be guided through it, and then they will leave with lozenges and gum that day. So that's session 2. Okay.
Hi.
Yeah.
Sorry.
You got the mic. You got the power.
Thank you. That was an interesting thing, like, to see computer model. One thing is is that only in the English language, or it has been like translated to other one like Spanish or the?
We haven't done that, but it certainly can be done because Amazon Polly comes in a lot of different languages. And do you want to add anything to that?
Yeah, no, I mean, I think ultimately we've actually spent a lot of time looking at the different plugins for different languages because we've been exploring different interventions in different countries. But we haven't, for this specifically, we have not done any translation. That would require, a fair amount of cultural adaptation as well, which we can do because that's what we do. But
Right.
This is where sort of we are now. But thank you.
Have you thought about using an avatar to represent the participant as well as the counselor?
That's interesting. No. I mean, I haven't, but I think it's an interesting idea. So you could do an actual, like a pretend counseling session. Yeah, that would be very, in fact, I can imagine, that's actually a wonderful idea, because for certain, I'm thinking like for trauma, that would be especially helpful because people are terrified about what the counseling session is going to entail, just from my own experience in dealing with clients. So if they saw a model session, that's an awesome idea. Thank you. Is it all right if we steal it?
No.
Okay, we won't.
For trauma.
For trauma.
Yeah, that's fine.
Okay. I think that's a great idea. I think, for a lot of reasons, counseling remains sort of a mystery to, and a stigmatized one at that. So, yeah.
Sorry, it's me again. So it sounds like you do envision this primarily as a counseling session within a clinic. Do you have, or have you thought about moving it off the computer onto a cell phone or other delivery methods? And were there challenges that prevented that sort of line instead of the computer model?
Right, you want to talk to that?
Yeah, no, I mean, ultimately, so that the platform is actually really flexible, so it actually could be moved. Initially, sort of when we first started this work, this was really, we were thinking a lot about how do we ensure that people have access to good evidence-based care. How do we integrate that into a clinical setting, which could be a clinic or a pharmacy, or, so we were thinking of kind of other sites. And I'll say for smoking in particular, so we have an alcohol intervention, and I can easily imagine the alcohol intervention being done on the home, doing it home, elsewhere, in part because we don't have great pharmacotherapy for alcohol use disorder. So a lot of that really is counseling and going through and then, hoping that you can then connect with someone. I think for me, conceptually, the difference with smoking is that we have really good pharmacotherapy. And so trying to do an intervention where someone can access that treatment feels important. Now, there may be other ways to be able to do that, like, you can order your nicotine replacement therapy and here it is, online or through an app. But I think that was one of the differences between tobacco versus some of our other interventions, where really the evidence really does suggest that we really should really try pharmacotherapy in addition to counseling. But yes, that sort of has always kind of been a plan to be able to extend.
One last question. Yeah, and I guess to just follow up on your updates that you guys are thinking about, are you planning on making it available in other languages, or?
Yeah, I think that's.
I think that's down the line.
Yeah,
I mean,
down the line.
It's
We have to get our alpha version of the, yeah, I think we get to get new software first.
I think the truth is this has really been a labor of love, and it's been several years labor of love of two people just doing this with a software person who lives in California and finding an animator, and like, so it hasn't, this is, it really is the Heidi and Geetanjali. Like, I mean, like, that's it.
Just
like,
moving along. It's hard
yeah.
with limited funds. I mean, we're very grateful to CRF, which has helped us tremendously, but it's difficult.
Thank you.
All right,
Thanks.
everyone. Thank you. Thank you to our speakers.